Hi, I'm Dr. Ali, a cardiologist with 3 decades of educational experience. Today, we're going to discuss pulmonary hypertension, pathophysiology, embryology, and how to interpret different tests. First of all, consider the miracle of birth. When you're intrauterine, there's high pulmonary vascular resistance, therefore, right ventricle has a difficult time. Blood circulation goes through the PFO. Once you're born, there's increased oxygen, nitric oxide, prostacyclin release, pulmonary vascular resistance plummets, and normal circulation starts, the PFO closes. In some people, there's a failure to transition, causing persistent pulmonary hypertension of the newborn. Now, in pulmonary arterial hypertension, 25 to 30% of the cases have a genetic background. The BMPR2 gene is the most common. It works through the TGF beta pathway. The other implicated genes are EIF2, AK4, and TBX4 and SOX17. These have different presentations. This just goes to show you that there is a genetic background, and patients with pulmonary arterial hypertension should be referred for genetics. Now, if you consider what the underlying problem is, the top half of this slide shows you a normal pulmonary artery. The bottom half shows diseased pulmonary arterial hypertension with medial hypertrophy, intimal fibrosis, and plexiform lesions. There is increased endothelin that causes excess constriction, decreased nitric oxide, decreased prostacyclin, and activin BMP remodeling imbalance. There is also additionally PA-RV uncoupling. The right ventricle gives the cardiac output towards the pulmonary artery. There is a fixed pulmonary arterial resistance. Additionally, the waves reflect back and causes increased pulsatile afterload. When there is a high afterload, there's RV dilatation, hypertrophy, severe tricuspid regurgitation, low cardiac output, and the PA pressure falls. So the RV and the PA can be uncoupled. You could use a CPET to unmask pulmonary arterial hypertension. The defect of low cardiac reserve presents as low peak VO2 and a flat O2 pulse. When there's ventilation of dead space, this manifests as increased VE/VCO2 slope. The perfusion limit VQ mismatch manifests as a low PET CO2. This is a simple non-invasive way of unmasking pulmonary arterial hypertension. Thanks for watching. More to follow in the series.